I am so sorry about that. And that happens at times. We think we're putting in the right thing and we wonder why it's not there. So this is why it's important to potentially have the correct first code. If we don't have the correct first code, if we put in something different, billing could be a problem. We're entering our second diagnosis. Has the patient had any other issues? They advise that they have had tingling in their feet, potentially. I'm just showing you sometimes the obstacles of looking certain things up. And we insert them. They go into our form. We're going to go to the next page. If you notice, this says saved 108. The document auto saves every 20 seconds. So while you're working in the background, the computer is saving your work. Good to know, right? We go to page 3. This page is also very crucial, because we do need to make sure that we have an emergency contact for this patient. We get their contact information, cell, email, what is the relationship to the patient, etc. Is this primary caregiver willing to assist? How are they willing to assist? They do some shopping and some home maintenance. What are the limitations of this patient? It is a required form, as it is a gray box. Obviously, ambulation could be a problem. Maybe even endurance, until they develop full functionality again. And everything else seems to be not applicable. We now start our comorbidities with our patient. They definitely have some vision issues. They presented to us. No nose problems, no ears problems. This definitely is applicable. We can write other. Post-operative right knee repair. Their speech seems to be fine. Again, we go through the prompts as needed. Of course, they have the right to refuse vitals. If we put the vitals in, patient checks their temperature daily because they understand the need to monitor their temperature for infection control. They weighed themselves daily. They did this morning before you came. This historical button will provide us information. At the next visit, we can look up our vitals without having to go back. Should we come back and see that their blood sugar is high or any other vitals seem to be off. We go back to save, we check our pain. The patient says they're fine, but it's really bothering them since they've been home, and of course it's most likely because they're walking more. Can they verbalize? Yes, they can. So we go from top to bottom, left to right, always on our note. The time up and go test. This is very simple. From when you get into the home, you're counting from the patient about 10 feet or so. So you're going to be counting in your head the seconds that it takes them maybe from the door to the chair that they're going to sit to. And the same when you leave, or should they go up to go to the bathroom. This gives us a rough approximation of their potential for falls. So this is about 11.5, and it says decreased risk for falls. It's just a little over the free mobility, but that's also because they're a post-op patient and they're just still healing. The integumentary section is good. We check their skin turgor. This patient really doesn't show much sign for worry about skin breakdown. They know when they have to go to the bathroom. I'm so sorry, that was me. They're slightly limited with their movement right now. They are never moist. They walk occasionally. They have slightly limited mobility. Their nutrition is excellent. Nothing has been impaired. And they have absolutely no reason to not be able to get up or sit for too long. So their friction and shear is decreased. Their 17 score is definitely not posing a high risk for skin breakdown. We hit save. Now we get to our wounds. These lovely numbers move around, so we know that they have a right knee. As you can see, I could put these anywhere, but we're just going to clear the image. So if you make a mistake, that's what you would do. You could take anything and pull it down. But for sake of convenience, we're just going to use one. Right knee. Potential first surgery this patient has had. Wound care done? No. Here we probably might need to write this if this is the directive. No drainage observed. The patient is aware of how to shower. So here we want to make sure that there are no skin breakdowns after we do our skin assessment complete of the patient. There's no reason to worry about any breakdowns now because the patient's young and mobile. So we want to put 1. We want to put right knee. We want to put a surgical wound. We want to put closed. Surrounding skin, obviously, we're going to indicate what it looks like. Is there any odor or anything to that effect? We can fill in whatever we can fill in. Drainage amount would be none because we didn't see anything coming from it. So we did indicate that the bandage remained dry, clean, and intact. Dressing to be changed on Wednesday with second nurse visit. Unable to see wound at this time. So we want to make that very clear and identifiable. Now we hit save. We continue through our body systems. Is the patient short of breath? This little section we sometimes miss. We think that their respiratory might be fine. Cardiovascular is fine. Have they had recent UTIs? And we move along. We know that they're diabetic. We go through that. We have another gray box and another field. So we kind of finish things page by page per our assessment. There's no effusion. If it's not applicable, please make sure that we fill that in. Our PHQ 2 is a standard form with any assessment. If a patient scores greater than 3, we have a PHQ 9 form in our forms section, which I will review towards the end, to let us know if we need to advise their caregiver or their doctor of any issues. This patient's mental state seems to be acceptable. We do a full risk assessment. They may not fall into any category here. We continue on down the line. They don't fall into any of these either. They might need some help with their ADLs at this point, of course. We review once again our packet information and the rights and responsibilities. We can never review that enough times. HIPAA, and inform them that all of their information is kept private. Briefly review emergency planning, especially with their recovery, to make sure, God forbid, in case of a fire or a natural disaster, that they will be able to maneuver themselves to where they have to go. Inform them of the state hotline. Review the advanced directives again. No OASIS. Let them know our agency number. Review sepsis, especially in this situation, to make them knowledgeable about the potential for any infection. Standard precautions and hand washing. Basic home safety. We add DMEs, their rehab potential. They seem to not give us any reason to worry that they shouldn't recover well. And we list anything that they may have. They have a cane. Now in this situation, they have diabetic supplies. We can add that if you don't find anything in the drop down. This is where it becomes very important. Our eligibility. Our eligibility, we must always select that a patient is not receiving palliative care, especially with the short term. We must always go through our homebound status. So at present, most likely a right knee is not driving immediately coming out of hospital post-op. So here they require the assistance of another person.